Good evening, everyone. I hope everybody doing well and on your preparation for your exam. We are here for you to help you to get super score. Welcome to this SUPERPoints MasterClass. And I would like to discuss some microbiology today. Please subscribe to our channel, get notifications. This is a year-long course, so come every week and get the super points that you must absolutely know in order to get a big score in your examination. Okay, this is all about consistency and dedication. If you do consistently and dedicatedly, you will get that success you have been looking for. So today, let us see some questions, very important questions. A 25-year-old woman develops wheezing, urticaria and hypertension within minutes of eating shrimp. All right. She is diagnosed with anaphylaxis. Which immunological mechanism best explains her condition? So we have 4 choices: deposition of antigen antibody complexes with complement activation, then IgE mediated mast cell degranulation and histamine release, then IgG autoantibody binding to cell surface antigens with complement mediated lysis, number 4 T cell mediated cytokine release and macrophage recruitment. So go ahead and take a few seconds to choose your best answer. So the best answer here is number 2. IgE mediated mast cell degranulation and histamine release. Okay. So histamine release is the key point here. First of all, know the topic. The topic is they're talking about. What are you talking about? That's a very important thing when you look at a question. All right. In fact, in everything, in every conversation, when somebody is talking about something, what do we think? What are you talking about, right? That's the topic. Once you realize the topic, your mind clears up. Same thing in examinations. What is this question about? What is the topic? So, in 1 second, if you know the topic, your mind clears up. The topic here is type 1 hypersensitivity reaction, IgE mediated anaphylaxis. So hypersensitivity reactions are classified into 4 types. Type 1, 2, 3, 4, right? So anaphylaxis after food exposure is the prototype of type 1 hypersensitivity. In type 1, we have IgE, mast cells, immediate histamine leukotriene release, anaphylaxis and asthma. In type 2, we have IgG, IgM against cells, and you can think about hemolytic anemia and Goodpatcher syndrome. In type 3, we have immune complex deposition. You can think about systemic lupus erythematosus, serum sickness, and post-streptococcal glomerulonephritis. All right. So when you want to think about these 4 types, okay, 4th is T cell mediated. You can think about TB skin test. That's a very important in exams. Okay, type 4 TB skin test. When you want to remember these 4 reactions, remember this one diagram. All right. When you remember this one diagram, then things get easy for you. So hypersensitivity reactions are exaggerated for or inappropriate immune responses causing tissue damage. Okay. and IgE mediated immediate reaction. This is like type 1. Okay. In type 1, anaphylaxis is the most important question. Asthma, all right, and an allergen binding to IgE on mast cells or basophils, triggering degranulation and release of histamine, leukotrienes, and cytokines. So think about those peanuts, okay? Peanuts, hypersensitivity, that's like type 1 reaction. So the antigen comes and it binds to IgE on mast cell surface, and mediators contained in granules in cytoplasm, they get released. All right, histamine and other mediators release it from mast cell, and the anaphylaxis happens. In type 2, it is cytotoxic antibody mediated hypersensitivity. IgG, IgM binds cell antigens, triggering complement or phagocytosis. The examples are hemolytic anemia, Graves' disease, myasthenia gravis. So you see the red blood cells with antigens on cell membrane, and then you can see the complement attaching to the immunoglobulins and antigen. IgG or IgM antibodies binding to cell surface antigens, activating complement or phagocytosis, leading to cell lysis or tissue damage. And finally, you got hemolytic anemia, membrane attack complex composed of C5 to C9 lysing red blood cells. Okay? So hemolytic anemia is a classic example of type 2 cytotoxic reaction. And in type 3, immune complex mediated hypersensitivity. Immune complexes deposit in tissues, triggering complement and inflammation. Examples are systemic lupus erythematosus, post-streptococcal glomerulonephritis, or serum sickness. And the antigen binds to IgG and leads to antigen-antibody complexes. They form in the blood, and then antigen-antibody complexes deposit in tissues, blood vessels, kidneys, activating complement and neutrophils, causing inflammation. Finally, you got post-streptococcal glomerulonephritis. Okay, so post-streptococcal glomerulonephritis is a classic example of type 3 reaction. Coming to type 4, this is also very, very important. All right, each type 1, type 2, type 3, type 4, every one of these will come in every exam. All right, do not go to exam without knowing these things. Okay, type 4 is very, very important. Delayed type cell mediated hypersensitivity. T cell mediated delayed reaction, 48 to 72 hours. Cytokines drive inflammation. The examples are contact dermatitis, PPD test, graft rejection. Antigen, the macrophage ingests the antigen, processes it, and presents an epitope on its surface in association with class 2 major histocompatibility complex protein. All right, class 2. The helper T cell is activated and produces gamma interferon, which activates macrophages. These two types of cells mediate delayed hypersensitivity. All right. T cells, memory T cells from prior TB exposure recognize PPD antigens, release cytokines, and recruit inflammatory cells. So right now, to test for tuberculosis, we are using skin test and blood test. In skin test, that is a tuberculin skin test, a healthcare provider injects purified protein derivative, tuberculin mycobacterial antigens intradermally into the forearm, and it forms a small veil, and a localized skin reaction after 48 to 72 hours measured in millimeters indicate a delayed type hypersensitivity response. Okay, so just remember one diagram like this: type 1, type 2, type 3, type 4. One diagram so that you are not confused, because many times we get confused. type 1, type 2, what is happening type 4, what is happening type, like that. So see all those 4 reactions in one place. Keep them in one place in your mind. And the best way is to go by the mnemonic. The super mnemonic here is acid. All right. Acid, this is a very classic mnemonic to remember these 4 reactions. All right. If A stands for allergic anaphylactic type 1 reaction, IgE, and it is immediate. All right. And then C stands for cytotoxic. C stands for cytotoxic, IgG and IgM, and cell surface antigens. And as I told you, transfusion reactions, Goodpatcher syndrome, type 2 reactions. I stands for immune complex. All right, that is type 3. And antigen antibody complexes deposit in tissues, serum sickness, and systemic lupus erythematosus. And D stands for delayed. All right, that is for type. So acid, just for an excellent mnemonic, and everyone can remember that easily. Okay, so it's a T cell mediated TB skin test and positive poison ivy, contact dermatitis. So for this case, the patient had immediate symptoms, right? He had immediate symptoms. So that is type 1 reaction, so A in acid. And the mechanism is IgE mediated mast cell degranulation. So look at the incorrect answers. The first one is immune complex deposition, and that is wrong. And it causes lupus, serum sickness, and PSGN, not immediate allergy. And number 3, IgG, autoantibody cytotoxicity, and type 2 is seen in hemolytic anemia transfusion reactions. And then choice 4 is also wrong, that is T cell mediated delayed response, that is type 4, and it is seen in PPD, in skin test, and contact dermatitis develops in 48 to 72 hours. So those reactions do not happen in minutes. Only type 1 happens within minutes. So that is the answer there. And the super formula is all about looking at a question and looking at certain, like pointing out certain key points and then going to the answer directly. So the super point here is whenever you see IgE mediated immediate hypersensitivity, all right, it is happening within minutes of exposure to a specific antigen. The mechanism is preformed IgE antibodies. They bound to Fc epsilon Ri receptors on mast cells. All right, they triggered rapid cellular degranulation, and they released preformed histamine, all right, and other things. Then they caused smooth muscle contraction, bronchospasm, GI cramping, vasodilation, hypertension, edema, increased vascular permeability, urticaria, angioedema, mucus secretion, and systemic anaphylaxis. So those are the kinds of words. If you see those words, and you can directly go to type 1 hypersensitivity. That is the answer if you see those keywords. And the super point is like something you should put to memory. All right. So the super point is type 1 hypersensitivity causes immediate allergic reactions like anaphylaxis via IgE mediated mast cell degranulation, unlike type 2 to 4, which are cytotoxic, immune complex, or T cell mediated. All right. So that is about allergic reactions, and definitely, all right, definitely you will get one question from these type 1 to type 4 reactions. Like they will either give you basic questions on the mechanisms. Sometimes they ask you backwards, like they will give you systemic lupus erythematosus and ask you what kind of mechanism, what kind of reaction is this. They might ask you contact dermatitis and say, what kind of reaction is this? They might ask you anemia, what kind of reaction underlying this anemia? Serum sickness, what kind of reaction? Goodpatcher syndrome, what kind of reaction? Like that. Graves' disease, what kind of reaction? So questions can go that way or this way. So make sure that you have good understanding of that concept. So next let us see this question. 3-month-old infant presents with recurrent anemia, pneumonia, chronic diarrhea, oral thrush, and failure to thrive. Examination shows absent tonsils and lymph nodes. Laboratory studies reveal markedly reduced T and B lymphocytes. What is the most likely diagnosis? Number 1, acquired immunodeficiency syndrome. Number 2, chronic granulomatous disease. Number 3, severe combined immunodeficiency. Number 4, X-linked gamma globulinemia. So read this question and answer in a few seconds. So the correct answer here is severe combined immunodeficiency. All right, again, what is the topic? Severe combined immunodeficiency is an X-linked interleukin 2 receptor gamma chain defect. Primary immunodeficiencies present early in life with recurrent, severe, or unusual infections. SCID is more severe due to defects in both T and B immunity. Genetic defect. Now, there are many. If you take a textbook like Harrison's, there is a long list, all right, like 200 genetic defects. But exams are all about what is most common, what is most frequent, okay? So think about what is most common, because remembering 200 different genetic defects would be impossible for anybody in the world. So genetic defect here, interleukin 2 receptor gamma chain mutation, ADA deficiency, resulting in absent T and B cell function. It's present in infancy with failure to thrive, chronic infections, and absent lymphoid tissue. All right. So how do you remember SCID? The supermnemonic here is SCID 3 T's. All right. Trouble, thymus, T cell. All right. SCID 3 T's. What is the trouble? And thymus and T cell. Remember the 3 T's. Those 3 T's helps you just to get a blueprint of this disease. What is the trouble? The trouble here is early onset infancy with recurrent infections. Thymus. Thymus shadow is absent. All right. That's another key word. No thymus shadow. And then T cell deficiency leading to B cell dysfunction. Combined T and B cell defects are common in this. All right. So coming to incorrect answers. Why is this AIDS? No. AIDS is not non-congenital. It presents later and not in early infancy. All right. And chronic granulomatous disease, the defect in NADPH oxidase is recurrent catalase positive bacterial fungal infections, but they have normal T and B cells. All right. And X-linked globulinemia, the defect in B cell maturation and recurrent bacterial infections after 6 months, and T cell immunity is intact. All right. So next, what is the SUPER formula? SUPER formula is about looking at keywords and going to the answer. Okay, what kind of keywords you see? You see this one, X-linked mutation of the interleukin-2 receptor common gamma chain, and then severely reduced T lymphocytes, then combined humoral and cell-mediated immunodeficiency. Patient has recurrent bacterial, viral, fungal, and opportunistic infections, chronic diarrhea, oral thrust, failure to thrive, and all of those things may be non-specific, but those things like X-linked mutation of the interleukin-2 receptor and absent or severely reduced T lymphocytes, secondary failure of B cell function, and fatal in infancy, absent lymphoid tissue, and bubble boy disease. That is also a very good word, a keyword specific to SCID. Okay, bubble boy disease. So whenever you see bubble boy disease with combined T and B cell failure, think about severe combined immunodeficiency disorder. All right. And the SUPERPoint is something you must remember. SCID presents in infancy with recurrent bacterial, viral, and fungal infections, absent lymphoid tissue, combined T and B cell deficiency, making bone marrow transplantation life-saving. All right. So that is a severe combined immunodeficiency. Very, very, very important. Okay, I cannot emphasize enough. I have seen this question so many times, so I don't want you to miss that. Next question is a 30-year-old health worker is screened for tuberculosis using a blood test that measures interferon gamma released from T cells after exposure to TB-specific antigens. This test avoids cross-reactivity with BCG vaccination, unlike the traditional PPD test. Which principle underlines this test? So there are 4 choices here. Read through these 4 choices and give me the best answer. All right, there are 4 choices. Give me the best answer. So the correct answer here is number 2, measurement of T cell activation and interferon gamma secretion in vitro. All right, this is the principle of IGRA test. Okay, that is the principle. And again, what is the topic? Interferon gamma release assays for tuberculosis screening. Tuberculosis screening can be done by 2 things I told you earlier. All right, a skin test or a blood test like IGRA, and there is another test called T-spot test. So tuberculosis skin test, it is a type 4 hypersensitivity reaction in the skin, but it cross-reacts with BCG vaccination. For example, if a patient has a previous BCG vaccination, they may come positive for tuberculosis skin test. Okay, but interferon gamma assay, a blood test where T cells exposed to TB antigens ESAT6 and CFP10 release interferon gamma, which is measured in vitro, more specific than PPD, especially in BCG vaccinated individuals. So the blood test, there you don't have this cross-reactivity with BCG vaccinated individuals. Okay. So what is the super mnemonic? Super mnemonic is TB. Just going by those words. T cells burst gamma. All right. T cells burst gamma. So TB antigens added in vitro, T cells, CD4, Th1 memory cells recognize antigen, and these burst gamma, they release interferon gamma, all right. So that is what is happening. You take the blood, all right. So a patient came to you, he is 60 years old. He says, I am in excellent condition, sir, I am fine. But his employer wants a tuberculosis test, preferably blood. So what do? You take his blood. Patient says, I am great. Still you take the blood. And in his blood, you are taking his T cells. Basically, these are memory cells. So you are adding the antigens, tuberculosis specific antigens. So when the T cells identify these antigens, they produce interferon gamma. And you measure interferon gamma and you say, patient has previous exposure to tuberculosis or even recent exposure. So that's a very important question, okay? For the rest of your life, you will get a question on this, and even people, because tuberculosis is becoming very, very common around the world. I'm seeing these patients even in the United States. So remember this thing, TB antigens, when they are added in vitro, the T cells recognize antigen and they release interferon gamma. So have a very good view of this, the intradermal PPD test, a healthcare provider injecting purified protein derivative tuberculin antigen intradermally, and you can see intradermally is giving, and the T cells, all right, the memory T cells from prior TB exposure recognizing PPD antigens, releasing cytokines, recruiting inflammatory cells, and you are seeing a localized skin reaction after 48 to 72 hours measured in millimeters, indicating a delayed type hypersensitivity response. And the PPD test is skin-based, it requires return visit for reading, less specific, affected by BCG or non-TB mycobacteria. All right. So then coming to this one, I already told you how this test is done. Blood test, it measures interferon gamma released by T cells exposure to TB-specific antigens, highly specific, unaffected by BCG vaccination or most non-TB mycobacteria, used for latent TB detection. So a blood sample is drawn and processed in your lab, and TB-specific antigens are added, and the T cells in blood recognizing TB-specific antigens releasing interferon gamma. And the result, if it is positive, we have a very good evidence of tuberculosis. All right. Now let us look at the incorrect answers. Okay. The incorrect answers, number one, delayed type hypersensitivity in the skin. This describes the PPD skin test, all right, not IgRA. Number three, immune complex deposition and complement activation. That is type 3 hypersensitivity, okay. I told you, right, immune complex deposition is type 3. That's not TB testing. And then anti-TB IgG antibody measurement. Serology is unreliable for TB, all right, since cellular immunity is the key, all right. So you are not depending on IgG, all right. You are depending on interferon gamma, all right. That's a very important point to remember. So next we have to look at the super formula for this, because super formula is all about looking at some keywords and finding the answer. So whenever you see in vitro diagnostic blood test that detects latent tuberculosis, whenever you see by measuring the release of interferon gamma from sensitized T lymphocytes, and patient's whole blood is incubated with TB specific peptides ESAT6 and CFP10, and memory CD4 plus T helper cells from a prior infection are present. They recognize these antigens and secrete interferon. So it has a higher specificity than other tests, tuberculin skin test, because it does not cross-react with BCG vaccination. So if you see those keywords, the answer is interferon gamma release assay, IGRA. The super point, what you must put to memory from this question is, IGRAs identify TB infection by detecting in vitro interferon gamma release from sensitized T cells, unlike PPD skin test, which measures an in vivo type 4 hypersensitivity reaction. All right. So very, very important concept, folks. Plus, remember that question. Next, let us see this question. A 60-year-old man with bone pain and recurrent infections is diagnosed with multiple myeloma. Serum protein electrophoresis shows a sharp monoclonal spike, M protein. Which statement best describes the abnormal antibodies seen in this patient? All right, there are 4 choices, and choose what you think is the best answer. Then we will have a discussion. So the correct answer here is choice 4. Immunoglobulins from a single plasma cell clone, identical in structure and specificity, seen in multiple myeloma and in vitro monoclonal antibody production. Okay, monoclonal antibodies. You need to know about monoclonal antibodies. Monoclonal antibodies are engineered proteins designed to bind specific targets, revolutionizing treatment and diagnosis of cancers, autoimmune diseases, and infections. And polyclonal antibodies, they come from different sources. Okay, the name says it all. Polyclonal, many clones. So there are different ones, and the diversity is heterogeneous. In a single clone, that is monoclonal, then the diversity is homogeneous. All right. So monoclonal antibodies, we have pathological conditions like multiple myeloma, and we also have therapeutic applications when you produce monoclonal antibodies and use them in different conditions. For example, in cancer therapy, there are many monoclonal antibodies like rituximab, trastuzumab, cetuximab, bevacizumab, daratumumab, pembrolizumab, nivolumab, ipilimumab. Then autoimmune inflammatory diseases, we see infliximab, adalimumab, omalizumab, tocilizumab, eculizumab. Then in transplant rejection prevention, we have basiliximab. And in infectious diseases, we are using pavlizumab, casirivimab, and imdevimab. So pretty much everything you can recognize easily by seeing those MAB. All right, MAB at the end, you are looking at monoclonal antibodies. So coming to this question, the topic is monoclonal antibodies and plasma cell dyscrasias like multiple myeloma. All right. So normal immune responses produce polyclonal antibodies made up by different B cell clones against various antigenic determinants. But in contrast, monoclonal antibodies are produced by a single clone, making them structurally and functionally identical. All right. So in multiple myeloma, you have these monoclonal antibodies. Okay, that's a very, very important disorder because we are finding this disorder in many, many patients. In fact, whenever I see this disease, my own dad comes into my mind because he suffered from multiple myeloma before he passed away in 2018. So this disorder, whenever I see this disorder, I remember my dad. And it's a very, very important disorder. More and more elderly people are being diagnosed with this disorder. So how do you remember this disease? So this is one good mnemonic. Myeloma makes mono. All right, myeloma makes mono. That's how you remember that monoclonal antibodies are common in this disease. All right, there is one plasma cell clone, there is one identical antibody, there is one sharp spike on electrophoresis, M protein spike. Okay, one clone, one antibody, and one spike. All right, and there is another classic mnemonic you can remember: multiple myeloma crab. Multiple myeloma crab. They have calcium elevated, hypercalcemia from the bone lesions. There is renal failure. There is anemia. There are bone lesions like pain, lytic lesions, and fractures. So crab is a very, very common mnemonic, and you can easily remember this to remember classic features of multiple myeloma. So the M spike is the diagnostic hallmark that explains the crab. Coming to incorrect answers, number one, many B cell clones. So this describes polyclonal antibodies, not monoclonal antibodies. Number two, random non-specific binding. Antibodies are always antigen specific. After vaccination, heterogeneous antibodies. So polyclonal response due to antigen diversity. All right. So those are incorrect answer. Coming to super formula, how can you identify a monoclonal gammopathy from looking at the question and finding certain keywords? So whenever you see pathognomonic immunologic finding in plasma cell dyscrasias, okay, and you see identical, structural, homogeneous, structurally identical immunoglobulin produced by a single malignant clone of plasma cells, and it results from the clonal expansion of one genetically identical plasma cell. And when you see it's detected on serum protein electrophoresis as a tall, narrow, homogeneous M spike in the gamma region, reflecting monoclonality. When you see the secreted monoclonal immunoglobulin M protein can vary, can cause hyperviscosity syndrome, renal damage, cash nephropathy, and displace normal monoclonal antibodies. So when you see those phrases or words, they are talking about monoclonal gammopathy. That is the super formula here. All right. So SUPERPoint is something you must remember. That is what monoclonal antibodies are: homogeneous immunoglobulins from a single plasma cell clone, as in multiple myeloma, unlike polyclonal antibodies, which are heterogeneous and arise from many clones during normal immune responses. So that is all about multiple myeloma. Next question. A 42-year-old man develops sudden oliguria, graft tenderness within 24 hours of a kidney transplant. Biopsy shows thrombosis of graft vessels with necrosis. Which mechanism best explains this rejection? All right, take a few seconds and we will discuss this interesting question also next. So the answer to this question is number 2, preformed recipient antibodies against donor antigens. So what is the topic here? The topic is hyperacute graft rejection in organ transplantation. So whenever you say there is graft rejection, ask what kind of graft rejection is this? Is this hyperacute, or is this acute, or is this chronic? All right, because everything has distinct timing and mechanisms. In hyperacute, that is like minutes to hours, like basically you did organ transplant, and before you even left the hospital, the nurse called you that the patient is not doing well. All right, so that is hyperacute rejection, and it is due to preformed antibodies. Complement activation happened. There is thrombosis and necrosis. And then there is acute. In acute, it is T cell mediated. There is lymphocytic infiltration. Then there is a chronic that takes months to years. There is vascular thickening, fibrosis, gradual loss of function. And there is another thing called graft versus host disease. Here, donor T cells attack host tissues. All right. So graft rejection is you received the graft and you are responding. And in graft versus host disease, the donor T cells themselves are attacking host tissues. So how can I remember this? I usually remember this way. Hyper is havos and humoral. All right, there is H here, and there is H here, and there is H here. H, H, H. Okay, hyper is hours and humoral. So it happens in hours, minutes to hours after transplant. And Y stands for you already have antibodies. All right, there are preformed antibodies. So it's a humoral reaction. And then there is P stands for platelet aggregation and thrombosis. And then E stands for endothelial injury. This is complement mediated. And R stands for rapid graft failure. So hyper, just expand those words, HYPER, and remember those 5 sentences. So it's very easy in that way. If you don't remember all 5, just remember hours and humoral. It happens within a few hours and it is a humoral reaction. And then how to remember all 3 reactions. The rejection time, hours, days and months. Hours, days and months. So hyperacute, hours, and acute, days, and chronic, months. So hyperacute is happening due to preformed antibodies. Acute is happening due to T cell mediated response. Chronic is happening due to fibrosis and vascular thickening. All right. Coming to incorrect answers, T cell mediated immune response describes acute rejection. Chronic vascular narrowing, that is seen in chronic rejection. All right, the words, I mean, it's almost silly to choose that answer, because we already said, like, if you see, it is saying like it happened within 24 hours, all right, within 24 hours. So you should not be choosing chronic. Usually chronic things don't happen within 24 hours, okay. That's a very easy option to rule out. And number 4 is also easy to rule out, because I told you clearly that describes graft versus host disease, not solid organ transplant, okay. And the SUPER formula is how you see a question and you see certain keywords and you go to the diagnosis quickly. So if you see catastrophic irreversible form of transplant rejection, occurring within minutes to hours, all right, that itself pins the diagnosis, all right. So it triggers a type 2 hypersensitivity reaction leading to complement activation and endothelial injury and resulting in widespread intravascular thrombosis, fibrinoid necrosis, and biopsy may show fibrinoid necrosis of vessel walls, neutrophilic infiltration, luminal thrombi, and it is hyperacute rejection. All right. Then coming to SUPERPoints. SUPERPoint is something you must remember. And hyperacute rejection occurs within hours due to preformed recipient antibodies against donor antigens, causing complement activation, thrombosis, and graft necrosis. So remember that SUPERPoint because you will have a question on this important concept. Next question. A 12-year-old boy develops fever, migratory joint pain, and a new heart murmur 3 weeks after sore throat. Throat culture is negative, but his anti-streptolysin-O titer is elevated. What does ASO test indicate in this patient? So, there is a patient here, fever, migratory joint pain, heart murmur, and his ASO titer is elevated. Now, what does that indicate? He has a positive test, and you need to tell what does this test mean, this test result mean. And there are 4 choices given. Go through the 4 choices, take a few seconds and come to the best answer you can guess. All right, folks, the best answer here is again number 2. It detects antibodies against streptolysin-O, indicating recent streptococcal infection. All right. What is the topic? The topic here is anti-streptolysin-O titer and post-streptococcal immune sequelae. All right. So let us see these important things like Streptococcus pyogenes. This is a question about Streptococcus pyogenes. Very, very important. In fact, it's not just about your exams. Throughout your medical career, this will follow you. This is the most common presentation. All right, whether you're a family doctor or primary care doctor, general medicine, this is the most common thing is sore throat. People coming with sore throat and what are the complications. So you should know this very, very well. So Streptococcus pyogenes is like chains of spherical gram-positive cocci and hemolysis beta hemolytic colonies on blood agar, clear zones of hemolysis. And if you look at its structure, and you will see M protein, lipotecoic acid, peptidoglycan, plasma membrane, cell wall, exotoxin, streptolysin-O. All right, streptolysin-O and streptolysin S. All right, so streptolysin-O and streptolysin. These are the things we are talking about. And exotoxins are important. And then what happens in the pathogenesis? They invade mucosa, skin, and they trigger immune-mediated damage in invasive post-streptococcal disease. Streptolysin-O is a pore-forming toxin. All right, it's a pore-forming toxin. And factor H binding helps streptococci escape polymorphonuclear neutrophils. And the clinical manifestations happen like this, like there is pharyngitis, patient with fever, sore throat, red inflamed throat with white patches. There is a scarlet fever. All right, they come with characteristic rash, and there is skin infections, impetigo, all right, and cellulitis, and there is also invasive disease like necrotizing fasciitis. All right, so it manifests in many different forms, and the sequelae, immune-mediated sequelae, are also very, very important. Post-streptococcal glomerulonephritis and rheumatic fever. These two are the sequelae. All right. So, streptococcal pyogenes is causes both direct infections like pharyngitis, impetigo, cellulitis, and immune-mediated sequelae like rheumatic fever and post-streptococcal glomerulonephritis. Since cultures may be negative once the infection resolves, all right, ASV titers provide indirect evidence of recent infection. So, ASV titers, they are not about active sore throat, all right, they are not about active strep throat, all right, they are about a recent past infection. That's a very important concept. So, how do you remember this? ASV. The mnemonic here is ASV, just say A for after, all right, A for after, S for strep, and O for occurred. After strep occurred, all right, ASV is after strep occurred. That means like not during the strep, but after strep occurred. That's a very easy mnemonic to remember, and I use this mnemonic to understand what ASV titer is about. It's not about during strep, but after strep occurred. A stands for antibodies against streptolysin O, indicates infection occurred earlier. All right, infection occurred earlier. You can also say it infection active occurred earlier. You can also put here earlier. After occurred. All right, this happened before, earlier. All right, this is not a recent, this is not an active infection. Okay, so ASV titers rises after strep throat, not during active infection. You can also remember rheumatic fever asks for ASV. All right, rheumatic fever, when you diagnose, remember Jones criteria for rheumatic fever, and it asks for ASV. Rheumatic fever diagnosis requires proof of prior strep. ASV titer provides that proof. Right. Coming to incorrect answers. What about other incorrect answers? Number one, active infection. All right, confirmed by throat culture. So if you want to see active infection, you need to do either rapid tests. You can do in your office, or you have to do a throat culture, all right, but not ASV. I told you ASV is not about active infection. And differentiate skin versus throat infection. No, ASV cannot do that. Anti-DNase B helps for skin infection. An antibody to DNase develops after streptococcal infections, especially after skin infections. And then detects M protein antigen. M protein is a virulence factor, but ASV does not detect it. All right. So now, how do you recognize these questions? That's where we use SUPER formula. Okay, SUPER formula here is a serological test, measures circulating IgG antibodies directed against streptolysin O. All right. So IgG itself should help you that this is not, because IgG antibodies are formed not in acute infection, right? In acute infection, we see IgM antibodies. So IgG antibodies do not form in acute infection. That's not the clue. So these are about IgG antibodies, and primary use is to provide serological evidence of a recent streptococcal infection, and weeks later immune-mediated sequelae such as rheumatic fever or post-streptococcal glomerulonephritis can happen. A significantly elevated or rising titer over 2 to 4 weeks confirms recent exposure, and the antibody test for recent group A streptococcal infection. All right, that is, they are talking about anti-streptolysin V titer. All right, very, very important concept. So what is the SUPERPoint? SUPERPoint is all about things you must remember. AS V titers detect antibodies to streptolysin V and are vital for proving recent streptococcal infection in suspected rheumatic fever or PSGN, especially when throat cultures are negative. All right. So AS V titers are a very important concept. Even this year we had questions on this particular topic. Okay, we are teaching only most tested topics. All right, this course is all about most tested topics. So these lectures are also about high yield topics. We are only doing high yield topics, and we are also emphasizing the keywords which you see in your exam, and we are giving you mnemonics so that you can remember those particular keywords. All right, folks, visit us at superpoints.ai. Superpoints are about what is most important for your exam. Like for example, 20 textbooks you read, right? 20-25 textbooks you see in so many subjects, from anatomy to embryology to all the way to surgery, orthopedic, psychiatry. You read so many textbooks, and you won't have time to go through all those textbooks when you're preparing for your exam. All right. So you need SUPERPoints that are most important to know about. The SUPERPoints you must remember. So this course is all about those things, and I will see you in the next episode. Thank you and have a good week.